بسم الله الرحمن الرحيم. محاضرتنا عن التونسيلايتس والادينويدز والاوبستراكتيف سليب ابنيا. انا احمد السبكي، استاذ مساعد انف واذن وحنجره، طب المنصوره. هنبدا بالكلام عن الادينويدز. الادينويدز اللي هي النيزوفارنجيال تونسلز، اللي هي الليمفويد تيشو اللي موجود في النيزوفارنكس. النيزوفارنكس اللي هو السبيس اللي بيهايند النيزل كافيتي. دي متكونه من vertical ridges of lymphoid tissue separated by clefts. بتتكون at birth ويبدأ يحصل لها physiological enlargement لغاية سن 6 سنين. بعد كده atrophy will happen around 12 years old. غالبا almost disappears by the age of 20 years old. This slide shows the anatomical site of the adenoid at the junction of the roof and posterior wall of the nasopharynx. The blood supply of adenoids. It is important to know the blood supply of the adenoids because one of our major complications or risky complications is the post-adenodectomy hemorrhage. So we must know where the blood supply comes from. It comes from ascending palatine branch of facial artery, ascending pharyngeal branch of external carotid, pharyngeal branch of the maxillary artery, third part, and ascending cervical branch of inferior thyroid artery of the thyrocervical trunk. Lymphatics from the adenoids and from the nasopharynx drain into the upper jugular lymph nodes, either directly or via the retropharyngeal and the parapharyngeal lymph nodes. Nerve supply is via cranial 9 and 10. Why does the adenoid get hypertrophied? Recurrent attacks of rhinitis, cold, sinusitis, even tonsillitis may cause recurrent adenoid infection and hypertrophy. Allergy also may play a role in adenoid hypertrophy. Yes. What will be the symptoms and signs? We have the nasal symptoms, the nasal obstruction, the commonest symptom. This leads to mouth breathing. Nasal obstruction also interferes with feeding or suckling in a very young kid, as respiration and feeding in very young kid can take place simultaneously. So a child with adenoid enlargement fails to thrive, not only because he can't feed well, but also because he does not sleep well. Nasal discharge is bilateral mucoid discharge. Chronic sinusitis is usually associated with adenoids due to diminished drainage. Epistaxis, when it is inflamed, it can cause epistaxis, which is not very common. Voice change or hyponasal voice. If the adenoid closes the Eustachian tube, we will have recurrent acute otitis media, and we may have secretory otitis media, which leads to hearing loss. Adenoid facies. Due to chronic nasal obstruction and mouth breathing, there is characteristic facial appearance called the adenoid facies. The child has elongated face, idiot, expressionless look, protruding upper incisors and overcrowded incisors, sometimes high arched palate. It's called adenoid facies. This is how adenoid facies look. We might have a pulmonary hypertension due to long-standing obstruction. Pulmonary hypertension can cause right-sided heart failure in untreated cases. How to diagnose adenoid? You theoretically you can examine the adenoid with a post-nasal mirror, but practice-wise it's not done. Best tool is to see the adenoid with a flexible nasal endoscopy, which is comfortable to the child. In older kids, we can even use a rigid endoscope, but it's much more straightforward to do a lateral X-ray on the nasopharynx, demonstrating the adenoid shadow and comparing its size to the airway. This is the X-ray nasopharynx lateral view and soft film, where we can see adenoid hypertrophy. This is the air column and this is the adenoid hypertrophy. Treatment of adenoids, if marked, is to do adenoidectomy. If the adenoid is moderately enlargement and there is associated pathology, we can treat. So if you have moderate adenoid with allergic rhinitis, we can manage the allergy. But if we have grossly hypertrophic adenoid, the treatment is adenotomy. We pass to the tonsillitis. We mean by the tonsillitis inflammation of the palatine tonsils, which line the oropharynx. Each tonsil is lymphoid tissue in the lateral wall of the oropharynx, between the anterior pillar and the posterior pillar. Anterior pillar is the palatoglossus muscle, posterior pillar is the palatopharyngeus muscle. It has medial surface facing the lumen and the lateral surface lying on the constrictor muscle. It have an upper ball and it have a lower ball. Medial surface of the tonsil have crypts. The largest of them is called dicta magna. Lateral surface of the tonsil, which is facing the constrictor muscles, have a capsule. The space between the capsule and the muscles is called the peritonsillar space. The anatomical features of the tonsil and relation to the surroundings. Blood supply, again, it's important to know the blood supply of the tonsil because we also have the complication of post-tonsillectomy hemorrhage, which is very risky. It's almost like similar to adenoid blood supply with small variations. We have the tonsillar branch of facial artery, ascending pharyngeal artery from the external carotid, ascending palatine of facial, dorsal lingual of lingual artery, and descending palatine of the maxillary artery. This is the blood supply of the tonsils. This the diagram shows in detail the blood supply of the tonsils. Venous drainage, they pass to peritonsillar plexus of veins, which join the common facial vein and pharyngeal venous plexus. Lymphatic drainage, lymphatics from the tonsil drain into upper deep cervical nodes, particularly jugular-digastric lymph nodes. Nerve supply is through the lesser palatine branches of sphenopalatine ganglion and the glossopharyngeal nerve. They provide central supply to the tonsils. We have the chronic follicular tonsillitis. This chronic hypertrophic tonsillitis, very big tonsils. It will lead to sleep apnea. The patient will have recurrent attacks of sore throat or tonsillitis, chronic irritation of the throat. He will have halitosis, thick speech, difficulty in swallowing, and choking spells at night, which will point to sleep apnea. When you examine the tonsil, it will be hypertrophied. You may find the yellow beads of pus. It may be small if it is a trophic type. You may have congestion of the anterior pillars in absence of acute infection, and you may have chronic enlargement of cervical nodes. Tonsillectomy can help with chronic tonsillitis. If you have a patient with acute tonsillitis, you can't do tonsillectomy. But if you have a patient with chronic tonsillitis, so tonsillectomy is a possible treatment. So, the complications of chronic tonsillitis is similar to that of acute tonsillitis: peritonsillar abscess, parapharyngeal abscess, intratonsillar abscess, and even remote infection in the form of rheumatic fever or subacute bacterial endocarditis or acute glomerulonephritis. Then we will come to the second part of our talk, which is snoring and obstructive sleep apnea. Sleep apnea is cessation of breathing during sleep. If it is due to upper airway obstruction, so it's called obstructive sleep apnea. If it is due to a problem within the respiratory center, so it's called central sleep apnea. So for ENT doctors, we usually treat obstructive sleep apnea due to upper airway obstruction. And in children, the most common cause of obstructive sleep apnea is hypertrophic tonsils and adenoids. Apnea in physiology means cessation of breathing more than 10 seconds. Let us learn some terms. What is the apnea index? Apnea index is the number of episodes of apnea that happens in 1 hour. What are the hypopnea index? Hypopnea index is the number of hypopnea events that happen during 1 hour's sleep. But what is hypopnea? Hypopnea is not cessation of breathing, but it is reduction of the airflow. Both apneas and hypopneas result from upper airway obstruction, so it is called obstructive sleep apnea syndrome, or we can call it obstructive sleep apnea hypopnea syndrome. Normally AHI is less than 5, so if the patient have 4 events of apnea or hypopnea per hour, this is normal. But if he have 6 events, so he has a disease. If the RDI, respiratory distress index, or AHI, apnea hypopnea index, is less than 5, this is normal. 5 to 15, this is mild obstructive sleep apnea. 15 to 30 is moderate, and more than 30 is severe sleep apnea. Arousal is transient awakening from sleep as a result of apnea or respiratory effort. Arousal index is the number of arousal events in 1 hour. Less than 4 is normal. Why do we snore? Muscles of the pharynx are relaxed during sleep, so there is partial obstruction. So if the patient already has narrow airway, any relaxation will cause snoring. Breathing against obstruction causes vibration of soft palate, tonsillar pillars, lateral wall of the pharynx, and even the tongue, even the epiglottis. Snoring may be primary snoring, which is only vibrations, or may be associated with apneas or hypopneas. Primary snoring is usually asymptomatic. It is not associated with daytime symptoms, but if the patient has apnea and hypoxia at night, he usually will have sleepiness in the morning. Any lesion obstructing the pharynx can cause sleep apnea. In children, adenotonsillar hypertrophy is the commonest. In adults, you may have nasal pathology, oral pathology, a thick palate, some laryngeal lesions, and other causes including craniofacial anomalies, obesity, sedatives, hypnotics can cause hypotonia and predispose to sleep apnea. So signs of snoring, signs of vibration can happen. Vibrations doesn't happen in the nose. It happens in the soft palate, lateral pharyngeal wall, pharynx, tongue, epiglottis. To treat the patient surgically, you need to know where vibrations happen and where obstructions happen. If the patient has obstructions and apneas at night, he will have daytime symptoms in the form of morning headache, fatigue, memory loss, irritability, sleepiness. Sleepiness is sleeping in unsuitable situation, like during driving or during watching TV, he gets sleepy. So these are the 3 types of obstructive sleep apnea. We have the obstructive type, which is due to obstruction in the pharynx. We have the central type, which is caused by a central lesion, and we have the mixed type. These are the consequences of obstructive sleep apnea, which can be congestive heart failure, hypertension, arrhythmias, ischemic heart disease. We may have a stroke, we may have sexual dysfunction, we may have diabetes, type 2 diabetes, and we may have sudden death in severe cases. Important point when we look to the patient with sleep apnea is to look at his body mass index, because morbidly obese patients are not surgical candidates. They are treated with bariatric surgery or with pressure therapy, which is the continuous positive airway pressure. So you must evaluate the body mass index. The next size, complete head and neck examination to detect the site of the obstruction and also to exclude space occupying lesions. Muller's maneuver is flexible endoscopic examination through the nose while the patient inspires against the closed nose to see the possible site of. To know the severity of sleep apnea, we need to do polysomnography. Polysomnography is the multiple sleep recording which calculates the apnea-hypopnea index and the oxygen desaturation index. Lifestyle modification, positional therapy, oral device that pulls the tongue forward, and continuous positive airway pressure are non-surgical treatments of sleep apnea. But when it comes to surgery, if you decided to operate upon the upper airway for obstructive sleep apnea, the first point is to know where obstruction happens. We need to do something called the DISE, drug-induced sleep endoscopy, to know where is the obstruction, and hence you can manage. You can do tonsillectomy, nasal surgery, oropharyngeal surgery. Uvulopalatopharyngoplasty is now historical. We now do lateral pharyngoplasty, which is more mucosa preserving. So UBB is a history now, but in the past it was the most common procedure performed for snoring. You may need to advance the lower jaw or advance the hyoid bone. You may need to reduce the size of the tongue base by radio frequency or by coblation, and you may need to advance the maxilla and the mandible to enlarge the pharynx